Heartfelt thanks to Dr. Veena for inviting me here today. That was an excellent presentation by Dr. Sivagami and Dr. Fatima on the non-strabismic binocular vision anomalies. This condition is not rare, but it is actually more misdiagnosed or undetected or undiagnosed, because I have seen many of my residents or postgraduates also have this, and they struggle with operating using the binocular microscope. So it is important to understand and manage this condition. So my topic given was to make it simplified. So I've kept it really simple. And we know that this anomalies can be basically accommodation and vergence anomalies. So I'll be dealing the management of the vergence anomalies after we have seen the accommodation anomalies. So vergence anomalies can be either functional or non-functional. The functional ones are more common, which we often see, and they can be convergence insufficiency, divergence insufficiency, convergence excess, divergence excess, fusional vergence dysfunction in which both convergence and divergence are abnormal, and the basic exophoria or the basic esophoria. The other non-functional ones like the convergence paralysis, divergence paralysis, or convergence spasm, these are more rare and not often encountered, and they are more associated with neurological problems. So these vergence anomalies can also be classified based on the AC by A ratio. So usually the insufficiencies are associated with the low AC by A ratio. The fusional vergence dysfunction and the exophoria are associated with normal AC by A ratio, and the excess ones are associated with a high AC by A ratio. So to make a proper treatment, first we need to diagnose the condition. So the four important tests which will take us or lead to the proper diagnosis include: one is measurement of the NPC, which we have seen. And even if we don't have the RAF rule, it can be simply done using a fixation target and measuring with a scale. And the vergence amplitudes also Dr. Shivagami has covered. So for convergence, we need to measure the positive fusional vergence amplitude. And for the divergence, we need to measure the negative fusional vergence amplitude using base out or basin prisms. This also we have seen. So after that, we can do a Fourier testing to check for any underlying ESO or exophoria and also measure the AC by A ratio. So once we have done these four tests, we can simply go in a stepwise manner to reach at the diagnosis. So with the Fourier testing, if there is no Fourier and if there is both reduction in the positive fusional vergence amplitude and also the negative fusional vergence amplitude, then the diagnosis is more likely to be a fusional vergence dysfunction, where actually there is problem with both divergence and convergence, and usually the near point of convergence will be normal or very slightly receded in this case. But on Fourier testing, if there is an exophoria where the eyes tend to go outwards, we analyze the convergence amplitudes, which is the positive fusional vergence. And if this convergence amplitudes are low, then we look at the AC by A ratio and also whether the Fourier is more for distance or more for near. So if it is a high AC by A ratio and the exophoria is more for distance, then it is a problem of divergence excess. If it is a normal AC by A ratio and the phoria is same for distance and near, then it is a basic exophoria. If it is a low AC by A ratio and if the exophoria is more for near, then it is a problem with convergence insufficiency. And here the NPC also will be receded. Usually it will be more than 10 centimeters. If the Fourier testing shows that there is an esophoria, then we look at the negative fusional vergence or the divergence amplitudes. So here again we check whether the AC by A ratio is normal, low or high, and also whether the Fourier is more for distance or near. If the esophoria is more for distance and it's a low AC by ratio, then it's a divergence insufficiency. If it is normal AC by A with equal measurements at distance and near, then it is a basic esophoria or it is a convergence excess. So now let's look at the management once we have made a proper diagnosis. So convergence insufficiency is the most common vergence anomaly, And this is the one which even general practitioners will come across, and it can be easily diagnosed. The important cause is it could be primary because of a wide interpupillary distance or because of a inadequate development of the convergence, or it could be secondary due to uncorrected refractive errors, which was already told by Dr. Fatima. So either a high hyperope, more than 5 diopters of hypermetropia, or even overcorrected hypermetropes, actually they will have a lower accommodation demand. Similarly, myopes and also presbyopes. So this low accommodative demand will precipitate the secondary convergence insufficiency. It can be also consecutive following a squint surgery if there is a recession or weakening of the medial rectus or a resection of the lateral rectus. So patients will have asthenopia and intermittent diplopia, which will be more for near. And the diagnosis can be confirmed by checking the presence of exophoria more at near and PFV less than 15, less than normal, a receded NPC, and a low AC by A ratio. So the treatment is first to correct the existing refractive errors, and then we can give the orthoptic exercises. So the most commonly used exercise many of you would have come across is the pencil push-up exercise, where the patient is asked to binocularly fix at the tip of a pen or a pencil kept at an arm's length and slowly bring it closer to the nose, and suddenly the tip of the pencil will appear double. At this point, they have to take effort and try to fuse and make it single. So this can be repeated multiple times in the morning and evening, and on follow-up, we can check whether there is any improvement. Other commonly used test is the CAT card test, which has to again be placed at an arm's distance, and with the other hand, a pen is placed in front of the card, and slowly the pen is brought towards the tip of the nose. So at one particular point, the two cats will start to fuse, and the patient will be able to see a single cat, and he should be able to maintain and sustain this position for some time. So this will help to converge the eyes and improve the convergence. So other cards are also available like the lifesaver card or the barrel card. Another important test which is commonly practiced by orthoptists is by using this Brock string test. So this is a string which has multiple beads and it is held in front of the tip of the nose, and the patient is asked to focus at the front bead, middle bead and the distant bead. So this will actually improve the both convergence as well as divergence, and it can be done repetitively. And this is also available commercially on Amazon. It can be even purchased by the patient and they can do it at home. So other orthoptic exercises that are used are actually training exercises with base out prisms. So these are actually called exercising prisms, which are base out, which are used, and they actually increase the convergence and help in overcoming the convergence insufficiency. These exercises can also be done using the synaptophore, and a trained orthoptist can actually train the patient for stimulating his voluntary convergence. So vision therapy softwares are also available now, like the Binox software, Ambligo, or HTS home vision therapy, where using computer-based exercises, we can improve the convergence. So despite all these exercises, if the patient cannot be improved on his convergence, then we have to go for optical treatment with spectacles. So here the relieving prisms which are used are the basin prisms, and we can ultimately even plan for surgical correction where we strengthen the medial rectus using bilateral medial rectus resection, and this can be done especially if it's associated with an exotropia. The other extreme is the convergence excess. Here also patients will complain of asthenopia, which is more for near, and there will be intermittent doubling of images. And on examination, there will be esophoria, which is greater for near, and there is a reduced negative fusional vergence. So the treatment is actually more common that we see is the accommodative convergence excess. So there will be a high AC by a ratio, and the treatment we can give bifocal glasses, and if there is no response, we can plan for a surgical treatment. Convergence spasm is a neurological condition and there is associated spasm of accommodation, and patient may have neurosis or hysteria, head trauma or encephalitis. And this first we have to treat the underlying neurological condition, and it can be diagnosed by the existence of the accommodative spasm and meiosis as a part of the accommodative spasm. So here we can treat also with atropine eye drops to relieve the accommodative spasm, which may relieve the convergence spasm, and also by giving plus lenses to relax the accommodation. So divergence insufficiency is again inability to diverge the eyes. So here the patient will complain of diplopia for distance, and this can also be primary, which is idiopathic, or secondary to neurological conditions. And divergence insufficiency is rarer when compared to convergence insufficiency. So here again we have to treat any underlying neurological disorders, and we give orthoptic exercises, and for exercises we need to use basin prisms, and if the patient cannot improve his divergence, then we need to give spectacle with prisms, and there we give relieving prisms which are base out prisms. And if patient is not happy with optical treatment, then we may have to go with surgical therapy with bilateral medial rectus recession. So last, coming to the divergence excess type of convergence disorder. So this usually is seen along with the intermittent exotropia, which are of three types. You have convergence insufficiency, basic type, and the divergence excess type. So this divergence excess, again, they will have diplopia and asthenopia for distance, and the exodeviation for distance will be more than for near, and there will be a reduced positive fusional vergence and a high AC by A ratio. So again, we can treat with orthoptic exercises. We can also give part-time occlusion, like similarly how we give for intermittent exotropia, which are actually anti-suppression exercises. And we can also give over minus lenses, which will actually stimulate the accommodation and also relieve the divergence spasm. And finally, we have to give surgery with lateral rectus recession or medial rectus resection. So the fusional vergence dysfunction is a disorder of both convergence and divergence. Here they will have asthenopia for both distance and near, and both negative fusional vergence and positive fusional vergence will be reduced for both distance and near. And there will be difficulty in clearing both plus and minus lenses with the accommodative flipper. But on monocular accommodative facility testing, usually it will be normal because it's the accommodation is normal. It's only the vergence disorder which is causing this problem. So for this also we can use the Brock string to train and improve the convergence and divergence amplitudes. Then coming to the basic exophoria, here the exophoria will be equal for distance and near. So patient may have asthenopia for distance and near. Here the positive fusional vergence will be reduced but the AC by ratio will be normal. And on MEM testing, there can be a lead of accommodation and patient will have difficulty in clearing with plus lenses. So the treatment will be to improve the fusional vergence using basin prisms. And basic esophoria, here the esophoria will be again equal for distance and near, and the negative fusional vergence will be reduced with a normal AC by a ratio. And on MEM retinoscopy, you will have a lag of accommodation and patient will have difficulty in clearing minus lenses. Here again we give orthoptic exercises, treat any uncorrected hyperopia if it is present, and we can give prismatic correction with base out prisms and also the vision therapy to improve the fusional divergence. So I would like to conclude that many of these fusion and vergence disorders, when you do the testing, you may find some abnormal values, but you need not treat all patients. So only patients who are symptomatic and who have vision problems, they have to be addressed with appropriate therapy. Thank you.